My name is Brambrink. I'm the chair at Columbia University in the Department of Anesthesiology there. I just assumed this position in July of last year. My angle to this field is basically my passion for the neuroscience in anesthesiology. Early on in residency, I basically started to be interested in the brain and its functions and possible risks for injury in the perioperative period. Got focused on the problems of cardiac arrest and resuscitation. And the outcome after that, and in particular in kids.
Yeah.
I had then the opportunity to spend time at Johns Hopkins, and then the last 13 years before I came to this new position, I worked at Oregon Health and Science University in Portland, Oregon.
Could I ask you to give me your thoughts on what constitutes an adequate general anesthetic?
Yeah, I think of an anesthetic as a way to make the patient tolerate surgery and to conduct surgery the safest and most optimal way. In other words, facilitate for both the patient as well as for the surgeon the period that need to be spent to do some modifications, repairs, alterations to the body. In terms of facilitating the surgical approach, I think I'm also focused on the patient's outcome there, because the better the patient is able to tolerate surgery, the better the surgical outcome will be. And so I think it constitutes essentially, from my perspective, a state where you are pain-free, where you are not aware of what happens to you, and in terms of surgical exposure, very often it also requires muscle paralysis. Obviously then, beyond that, it's really all about maintaining physiology and correcting the side effects of the surgical trauma, which is, I would say, 60 to 80% of what an anesthesiologist does is basically maintaining physiologic state, homeostasis, and on the side give drugs that maintain these three necessary goals, achieve these goals: painlessness, unawareness, and basically relaxation. And it's a process. It never is like an anesthetic, but it's providing anesthesia every moment. So you need to adapt it constantly to the needs of surgery and to the needs and tolerance of the patient.
Yeah. Okay. Thank you for that. I'm sure you're aware that some of our colleagues consider that amnesia is really important, and some might go as far as to say it might be okay for the patient to have distressing experiences intraoperatively, providing they don't remember it afterwards. How do you feel about that?
Yeah, I think of that as being not the ideal state of an anesthetic, period. If I go and consider scenarios where it could be the least of all evils, it could be a scenario where a patient is very unstable, and cannot tolerate the side effects of anesthetics to the level that would be ideal, as I described earlier. But those should be then as best as possible ameliorated, so that I could be able to maintain the anesthetic state at the level as I described it before.
Sure.
I think else it would be ignoring the fact that I believe the mind, while not conscious at a certain time, fully conscious or not aware or not remembering, still will be influenced at other levels that will imprint basically this trauma into that mind, and will probably transform that individual into a different individual. So I think the goal of just providing amnesia, I think, is not one that I would have except of in under extreme circumstances.
Sure. Okay. So you to my mind, you're saying that there may be something like implicit emotional processing going on intraoperatively under those circumstances, which may have adverse effects even though the patient has no explicit recall.
Yeah, I think, I have no doubt that the mind operates at several layers, one of which is our conscious mind.
Sure.
We don't have knowledge about our past, for example, until maybe the age of 5. If you think about your age, about your life between day 1 and age 5, 6, you will probably not remember anything, if at all, maybe a life event of sort. Yet you were transformed into what you were in those years.
Sure.
Meaning, if I don't have memory, that doesn't mean that things haven't happened.
No. So in fact, you were talking about something even more fundamental, which is an impact on personality characteristics.
Yes, I'm sure that the other good example would be trauma scenarios that people forget.
Sure.
Being abused.
Sure.
Being punished, being in war situation, and then later, 50 years later, having severe mental problems, personality issues, and so forth. And then people, if they can do it, search help, professional help, and identify something happened 50 years ago that actually determined their lives today.
So you're an expert on neurotoxicity of anesthetic agents. What do you say to the argument that the evidence for psychological impact or psychopathology of the kind we've just been talking about as an effect of too light an anesthetic, to summarize, versus neurotoxicity, so that we are in this sort of tightrope scenario where on one side we have neurotoxicity and on the other side we have risk of awareness. Mm-hmm. So what would you say to colleagues who would say to you, I think there's more of a reason or more evidence to worry about neurotoxicity than there is to worry about post-operative psychological problems?
So I would, to me, this question propels me back to my passion for the brain and to my passion for research. I say to these people, we don't know enough. My hope is for the next 150 years that we know more and understand better. the brain to the same level as we now today understand the heart
Yeah.
or the liver. We even there have a lot of gaps that we don't understand, but
Yeah.
the brain is, for the most part, a black box. If not even further, we should be conscientious about the fact that the mind is even a greater black box, and body and mind as a problem has not been even closely solved. So we don't have a lot of clues. So my first answer to those people would be, I don't know.
Mm.
My second answer would be, I'm a person of common sense, so I would put together what I know. So as you mentioned, yes, there's clearly, I think, there's clearly evidence, but not real true understanding that how all the details work together, what the mechanisms are, but that trauma can long-term influence the mind, that results in long-term sequela,
Yeah.
that people
Yeah.
can be broken by it, can be even
and the evidence for this is outside of the field of anesthesia. It's in terms of childhood trauma and
Right.
all that literature, which is very well researched now. We know quite a lot about the impact of childhood trauma on adult life and personality, as you referred to.
And if we are talking about, if we discuss the risks of neurotoxicity, I would say there are two risks. One is the risk of toxic effects of anesthetics to the developing brain. Experimental settings, we know relatively certain now what happens. We don't understand why it happens. The nerve cells are killed, synapses are deteriorated in their functions, in their density, axons are eliminated, dendrite connections are removed or altered, because there are studies that indicate that at least longer exposures or multiple exposures to anesthetics in the context of surgery are can have deleterious effects for development. So I would say that there is a certain risk being exposed to anesthetics. I would at this point say any drug that is studied has had effects in the laboratory that were, when the doses were high and the durations were long, had effects of that type I described before. I would argue less of that drug in combinations with other drugs that go synergistically in the same direction, providing deep enough anesthesia, combining it with opioids, which have been in the pediatric environment shown as not toxic so far. Combine that together with an amount of anesthetic that is adequate, and combine it with a multitude of different anesthetics that work synergistically, and look for a few drugs that are sedatives like dexmedetomidine that could be also added to a cocktail that then could potentially be considered alternatives, although we don't know enough to really be sure. Now, as I said in the beginning, in a situation where we don't know enough, a pragmatic approach is maybe one that I would take. Nevertheless, I would always come back to my quest that adequate anesthesia is one that's deep enough to provide unconsciousness and deep enough by all means to provide pain, the absence of pain.
Sure.
In the adult life, we are talking now about neurotoxic effects of anesthetics. If we are talking about delirium after anesthesia, and in the context of in the context of surgery, is another concern, where people argue, well, we are currently providing too deep states of anesthesia, with the obvious concerns that if we would lighten that up, maybe patients would be more likely aware of their surroundings
Sure.
and would be traumatized by being aware in a situation, or would get less drug to be not completely pain-free. I think that, again, there needs to be a lot of efforts in the sciences of anesthesia to figure out what the mechanisms are and what the alternatives are. In the meantime, pragmatically, I would say, again, combinations of drugs at lower doses in combination with probably higher amounts of pain medication, with a multitude of different pain medications. Now, we call that multimodal analgesia as a baseline, basically a rock on top of which you only need a certain amount of drug, of anesthetics to keep somebody under. Those would be pragmatic approaches at this point. Brain monitors have been developed in recent years. I do believe, again, there that we are just scratching the surface of our understanding. We need to be truthful that we don't have too much insight into what happens actually during anesthesia and surgery in the brain, and what happens to the mind. Therefore, we have to aim for middle ground that is pragmatic. That being said, I do believe both needs to be done at this point. One, a pragmatic approach to not giving too much drug, at the same time fostering research wherever we can and discussing the issues.
Sure. I was very struck by something that Maria Fitzgerald said today, which was that we are so preoccupied with neurotoxicity, we seem to forget that actually the child's experience of an aversive, a noxious stimulus may also have effectively toxic neurodegenerative effects. What did you make of that?
Yeah, as the experiments that other people do, these experiments obviously uncover problems, and I think it's very striking what her lab has produced in recent years. I think the possibility that a previous surgical experience that was not adequately covered can actually cause hyperalgesia in later periods of life when pain occurs. If we test kids at 10 years or 15 years of age who had been exposed to anesthesia and surgery when they were little, if we see behavioral impairments or learning difficulties, we could see the summation effect of two things. We could see that there was an effect of the anesthetic at a young age, which resulted in certain consequences, and potentially also the effects of surgery, of the surgical trauma that happened to be happening at the same time, which was not 100% covered by the anesthetic, because quite frankly we know that the brain doesn't shut down under anesthesia. It continues to be a sensitive organ. So we could see both of these effects at the end. The next step there would be to test both in a series of experiments, or kind of a whole program of experiments, where you test adequately enough what happens long term with both surgery as well as anesthetic, and in combination.
Sure.
I do think that line of research that Mary presented today was striking, and it clicked to me as thought-provoking for new experiments.
Sure. It struck me that one of her points was that she herself was rather surprised at the apparent neglect by the anaesthetic community and the neuroscience community of the idea that noxious stimulation itself could cause neurotoxics, not the right word, but you know what I mean, deleterious effects to the developing central nervous system. I think she was getting at something quite philosophical about the profession and its preoccupations.
Obviously, we look with a certain perspective on reality that is determined by who we are and what we do every day. I would, however, say that anesthesiologists in general are actually driven by the desire to limit pain
Of course
and suffering and death.
Can I just ask you now a little bit about intraoperative characteristics and occurrences, phenomena? If you're involved in delivering an anaesthetic in your current practice, which I understand is neuro anaesthesia, if you notice a limb movement, what would go through your mind? What would you be thinking about that, and what would you do about it, if anything?
Obviously, we need to think about the context. So, in a scenario where this would happen in a patient that is operated on, I would consider it as a sign for awakening of the patient. I would deepen the anesthetic.
Right.
It could be that obviously you could have a scenario where there's surgical stimulation to a certain area of the central nervous system or peripheral nervous system.
Sure.
They could elicit this limb movement, and I would then communicate with the surgeon to identify the true cause. But if I had any concern about wakefulness, I would deepen the anesthetic and then would deal with the potential side effects of that deepening.
Sure. Would you ever speak to the patient?
It's an interesting thought. Initially, I would not. I would rather try to do something pharmacologically about it. Thinking about the option to talk to the patient is an interesting one. I think the concern that I had in this moment would be to potentially frighten the patient, because I would have not talked to him or her before that I would talk to him or her during the case, potentially. But I can see that maybe talking to the patient, if I do it in a way to take contact, to make contact to the patient and try a minimalistic communication, I could also consoling the patient.
Reassurance.
Reassure. If we would consider the state that somebody is under anesthesia really a state where the person would have full consciousness, but there could be an extreme situation where it actually would be an important consideration to talk to the patient. Now that I'm thinking about it, it's often not that easy, because you often do not have access to the head.
No. Okay.
In anesthesia.
Sure.
But I would say at least in 50% of the cases you do have.
Yeah. Would you have any concerns about what your surgical colleagues would make of you speaking to the patient?
No, I would not, and It wouldn't immediately. I mean, that would be not a consideration that I have in that moment. I'm the patient advocate.
Yeah.
I'm actually the only patient. I mean, I'm the primary person for the patient,
Yeah,
as compared to the procedure.
That is so true. Yeah, absolutely.
And
Yeah.
I mean, growing up as an anesthesiologist, I would say that is the third of my worries. The first is obviously that the patient is stable. The second is that the procedure goes well. And if the surgeon would think anything of me or the patient or the scenario, he or she could talk to me later.
Sure.
And if he starts or she would start talking about that right now, I would ask to talk later.
Sure.
Outside of the patient treatment.
I'm wondering if the reason why you don't have any concerns about what the surgeons might think of you for talking to the patient has something to do with you having trained in Germany. Have you trained in Germany?
I did.
Train?
Yeah.
I'm wondering. The reason why I'm asking you this is that you, I think, are about the 6th expert that I've interviewed on camera, and what's been coming through, interestingly, has been an issue about the politics of the operating room. And this does seem to vary by country, and the United States seems to be one country where the hierarchy between surgeon and anesthesiologist is particularly marked, whereas perhaps in Europe and the UK it's not as marked.
It is possible.
Mm-hmm.
I think I think hierarchy and hierarchy are two different things. One hierarchy, I think, is a clear, determined one that is the surgeon indicates surgery and is responsible for surgery.
Mm-hmm.
So whatever happens needs to take that into consideration. Hierarchy is a hierarchy over another attending expert in the room for anything that is outside of the surgical procedure, meaning the patient communication, the anesthesia for that matter, the physiology, anything like that. I think that the hierarchy there does not apply. The hierarchy that I was talking about before. In fact, I think that I mean, you're asking me about something